This material is for reference and educational purposes only. SimKit, its authors, and associates assume no responsibility for the utilization of any knowledge, materials, or techniques shown or described, nor do SimKit, its authors, or associates assume any responsibility for patient safety or outcomes. Clinical experience as well as current guidelines should determine the exact procedure and processes in each individual patient.
Hello, everybody, and welcome back to the SimKit podcast. I am joined today by an awesomely special guest. We are happy to be joined by Dr. Kraftin Schreyer, who I had the pleasure of calling my co-chief when we were at Temple EM residency program together. Kraftin is definitely a no-nonsense workhorse of an ED doc. I think I credit all the knowledge or skills that I have as an EM clinician to trying to keep up with her during our training. She is an associate professor of emergency medicine at the Lewis Katz School of Medicine at Temple University, an ED medical director, an ED administrative fellowship director, and a medical director of capacity management. A busy individual for sure. So Dr. Schreyer, thanks for being on this podcast, and tell the listeners a little bit about yourself and what you do now in the world of EM.
Jay, thanks so much for having me. It's really awesome to have this opportunity to speak with you about operations, which you know is near and dear to my heart. As you mentioned, I'm an attending ED physician at Temple in Philadelphia, and I currently split my time about 50-50 between clinical shifts and administrative responsibility. I've been involved in ops since residency, and I've continued to expand my involvement as my career has progressed. I've been a medical director for the past 6 years, and I've run our EM administrative fellowship since inception in 2018. More recently, I've also assumed the role of medical director of capacity management for our health system, which really affords me the unique perspective of looking at operations both from the ED and inpatient sides.
Awesome, and congratulations on that role and title, the medical director of capacity management. Yeah, it makes you the perfect person to talk to today about really probably the bane of every EM physician's work life. It's ED overcrowding and boarding. So I wanted to talk on this topic because really it just doesn't seem to be getting any better. We've all been there, right? We've all had more patients in your waiting room than beds in your department, admit holds in the double digits if you have a big department, triple digits maybe, trying to put portable tele on your AFib RVR patient in the hallway. It is a nightmare. So now, Kraftin, there is so much to talk about here, but I wanted to keep things tight, focused, and evidence-based. Sound okay?
Sure. I mean, I could talk about this all day, but we can keep it tight.
Keep it to the high-yield topics for the ED physician. So my first question for you is, we kind of often marry the two, right? We marry ED crowding and boarding. We see them as kindred spirits. But is there a difference really from an operational standpoint? Should we be addressing boarding with a different mind frame than we do ED overcrowding?
So the short answer is yes. From an operational standpoint, there is a difference between crowding and boarding. But I'll say the two are very closely related. Crowding is really defined as when demand exceeds supply. So the need for emergency services exceeds the available resources available for patient care, in the ED and the hospital or both. Boarding, on the other hand, is really the extra, quote, extra time an admitted patient spends in the ED. The Joint Commission notes this is a patient safety risk and says that it shouldn't exceed 4 hours. But I'll say that there really isn't a shared definition of boarding across emergency medicine. We typically fall back on that Joint Commission definition of 4 hours, but maybe that's not the right number. So boarding, this extra time directly contributes to overcrowding. The longer the patients are holding in the ED, the fewer beds are available then to see new patients, and the more crowding results as new patients present for treatment. I know we all really feel this, like you said, kind of more so than ever now. But I'll say that if anyone's looking to read some more, there was a recent study in JAMA from 2022 that did a nice job of quantifying boarding in the context of what we call access block, which is, also known as hospital occupancy. So if there are no inpatient beds, then ED patients can't leave the ED to go to an inpatient bed. That particular study found that during the pandemic, the median ED boarding time was just over 6.5 hours when hospital occupancy exceeded 85%, compared to just under 2.5 hours when hospital capacity was less than 85%, which tells you a lot about how the hospitals should operate from a purely flow perspective. But anyway, yeah, so boarding, I guess, is the primary driver of ED crowding, even though the two are separately defined. But to effectively address crowding, we have to address boarding.
That makes sense. Yeah, one kind of leads to the other in its own right. Like if you dam up the river, it's just going to backflow. If people can't get out, there's no space to bring people in. The boarding leads to crowding. Okay. So let's then tackle boarding first. You have a 40-bed ED. On Monday, you come into your 5 p.m. rush with 21 admit holds. Kraftin, break down your approach to managing this horrible situation. Let's talk first about what we can do or what can be done in the department to help.
Yeah, unfortunately, not much. And if people are looking for quick fixes, I don't know that I'm going to be able to offer them. In this particular situation, this is really bad, right? The ED is dangerously overcrowded. On the surface, this looks like an ED problem, but it's not. I think most people listening to this know that. It's really a hospital or health system problem. So my recommendation would really be for the ED to push whenever possible and not rely on the floors to pull. As an example, if an admitted boarding patient has a ready bed, get them out of the ED. That might mean modifying how your nurse report is given. So maybe giving a one-call attempt before sending the patient up with some documentation in the EHR rather than waiting for that verbal handoff to happen. Or potentially not relying on third-party transport. So if you have someone in the ED that you can spare to take the patient upstairs, that might be a good use of that resource. The other solution, which I'm sure many listeners have been a part of, but is not ideal, is getting creative, which is seeing new patients in, quote, non-traditional ways, which might include hallway beds or waiting room medicine, which is, not optimal for patient care. I've seen EDs that have surge plans that are enacted when the ED hits critical points of overcrowding, but there's only so much that can be done within the four walls of the ED to address this because it really is an external issue. You always have the option of going on EMS diversion, which we're all familiar with. We know is a patient safety issue and really addresses input, which is not the part of ED throughput where the boarding problem lies. That's an output access block.
Yeah, that makes sense. And I like the idea of the push versus pull model, right? Because part of the challenges are, and there might be a different mentality. I don't know the culture of a lot of, inpatient nursing or doc flows, but if we're busy, that usually means they're busy, right? Once we get over 85%, you mentioned, we're going to start seeing this problem. And so taking on that next patient may not be the high priority option in a nurse that's approaching sign out. They might hold on that report call for much longer than we want to. So the idea of us driving that movement makes a lot of sense to me.
Yeah, I think it's underutilized. I think you hit the nail on the head. They're busy, but we're busier, I would argue.
Yep.
We have the impetus to prioritize that care for our patients. Frankly, they don't.
Yeah.
So anything we can do to drive that bus is a good thing.
Yep. All right, and then excellent. We, as you mentioned, once the die is kind of cast, once you're at more than 50% of your beds being occupied by boarders, as you mentioned, there's only so much you can do. Getting creative, rotating people through chairs or triage stretchers to see them, put them back in the waiting room, get labs, CT scans, what have you. We'll do what we can there, and many people are familiar with that. But as you mentioned, this is an external issue. So what changes can be made upstairs to deal with this backlog?
That's a great question. In the moment, any pending discharges should be reviewed and expedited. That's kind of a given. If your hospital has a discharge lounge, it should be utilized. I'll also take the moment to say that a lot of discharge lounges out there have really strict criteria, which makes them less useful than they could be. So if you have an opportunity to look at a lounge you might have, I would try to expand it to allow more patients to use it. But anyway, these in the moment actions regarding the discharge patients that are ready to go that day realistically take hours to implement and don't have the impact we want in the ED right away. So really you got to think ahead on the inpatient side. You want to avoid that backlog entirely and taking actions well prior to that kind of critical moment. The best practice is really to plan for discharge on the day of admission, which a lot of people say they do, but don't actually do. There are electronic health records out there that have tools to assist in discharge planning, like an estimated date of discharge and discharge milestones. that help identify an anticipated date of discharge and any potential barriers to actually being discharged on that date. Then it allows, some other party to help act on those barriers. Another best practice is early discharges. So getting inpatients out of the hospital before mid-afternoon, when the admissions from the ED predictably start to increase, that will help smooth flow. Continuing discharges through the weekend in particular helps flow going into a Monday. Like the scenario you described, it's a typically problematic day for both boarding and crowding. So that 24/7 hospital model over the weekend is really key. And then lastly, I'll just say that, other actions that can be taken on the inpatient side, you could use inpatient hallway beds like we do in the ED. You could also work with your operative services to smooth elective admissions and operations. All of those have been shown to have positive impacts on ED boarding and therefore ED crowding. But they're not common, particularly the latter one, because there are financial implications and anticipated need for increased weekend staff that a lot of health systems can't or don't want to meet. The former, the inpatient hallway beds, is less common because of pushback from nursing and regulatory teams, but it has been done. Opening unstaffed beds, maybe by expanding nursing ratios, is also an action that can be helpful for the ED, but also one that's not easy to implement. And then the final one I'll say is optimizing turnaround times for EVS and transport. Helps hospital throughput and therefore ED throughput.
Yeah, that all makes sense. And those structures and systems, as you mentioned, trying to say, how do we get ourselves out of the hole we're in on Monday, at 5 p.m. If none of this is in place, you can't, right? Unfortunately, all of these take hours, days, weeks, months, depending on the committees involved. But there are a lot of great practices in there. And there are a lot of practices that really should be incorporated into a surge plan that I know our hospital has. I believe, Temple System has the same, that allow for, incremental increases in these areas. And it is definitely a culture change. And I feel like I'd like to talk a little bit about sort of C-suite or CMO buy-in of if our ED nurses have a ratio of patients and they are just doing everything they can and staffing well above that, it's not unreasonable to ask that of our upstairs colleagues, or for the patient whose bed is being cleaned to be going through intake in that hallway. Do a lot of hospitals want to practice continued inpatient hallway medicine? No, it's not great for patient care. It's not great for satisfaction scores. But in that that 5, 10, 15, 20 minutes between when their room is the patient's discharged and it's clean for them to enter, that opens up space where we can do more care in the department. So tell me, if you can, any thoughts you have about recognition of buy-in from upstairs in being a counterpart of ours and really the other half of this problem.
Yeah, I think you bring up a lot of good points there. You certainly need C-suite buy-in to get a lot of this done, and nursing leader buy-in. Not necessarily nurse managers on the floor, but like the CNO, and those direct reports. There's literature out there that shows that inpatients get different care than ED patients versus ICU patients versus observation patients. So adjusting the ratios to get the patients where they need to be for the level of care that they need makes sense. Along that line, I'll also take a minute just to tell your listeners to advocate for additional resources for the ED. So if you're finding yourself in a place where your ED nurses are stretched thin, maybe you're short-staffed, you're boarding a bunch of inpatients, sound familiar, anyone? You should ask for inpatient nurses to come down and help with those boarding patients. Even if there's no bed upstairs to send them to, the level of care that they require is not that requires an ED nurse, frankly. So, best practice in my mind would be having the appropriate nurse care for the appropriate patient. So getting those inpatient nurses downstairs to care for those cohorted boarded patients would free up your ED nurses to do, ED care.
Yep. That's fantastic and makes a lot of sense. And we are lucky in our hospital to be able to do that on occasion, depending on the number of boarders. When we hit a certain level, we will try to grab a upstairs nurse to work with a zone of our department that's all admitted patients. And it, like you said, it involves your CMO, your CNO getting those people involved. One thing I'd like to ask from you is, references and resources. We have several related to the harms, right? There's plenty of data about the harms of ED boarding, but things that people can bring to these C-suite people or these leaders to sort of show the need and how we all can work cooperatively to make actual gains in terms of patient safety.
Yeah, I mean, there's a good amount of literature out there, like you said, on the problems. The one I think that is the easiest read that and is easily translatable when you're talking to the C-suite is the article in the New England Journal by Kellen et al., The Canary in the Coal Mine. We're probably all familiar with it. It came out a few years ago. I can send you the actual citation after this, Jay, if that would be helpful.
Yeah, that'd be perfect. I think people in the operations world are probably quite familiar with it, but if people are looking to engage themselves in this beyond their throughput committee, their ED physicians without that background, having that foundational information would be fantastic.
Yeah, absolutely.
So now I kind of want to talk about what intuitively seems like a logical answer, but probably isn't, may not be. Why are we not just making hospitals bigger? I've heard in the prison system, for example, that they've considered building more jails to address the prison overcrowding system. Some have tried it, I believe, and what they find is that when you build more jails, you simply end up with a larger scale crowding issue. So if building more beds is not the solution, why is that so?
I think that's a great question. And I'll put aside the cost associated with an expansion,
millions
right?
And millions, yeah.
The monetary cost, the physical plant cost. But, just speaking, if you had unlimited resources, if you build it, they'll come, right? Before I get into the expansion answer in detail, I just want to share one piece of key operational thinking that kind of runs through my mind when I think about solutions, is that every process, every operational process has servers that are required to complete that process. So throughput, whether in the ED or the hospital, is contingent on three key servers: beds, nursing, and physicians, or NPPs. One server always serves as a bottleneck in the process. Ideally, the physician is the bottleneck, but more often than not, that's not the case, right? So when we're boarding, beds are often that bottleneck, or if you're short-staffed on nursing, that can be the bottleneck. And as I mentioned, neither of those are ideal. We want it to be us. But anyway, back to your expansion question. So expanding an ED without any expansion on the inpatient side is not going to fix boarding or crowding. The reason being is in most EDs, current admission volume from the ED exceeds that of the boarding patients, right? So with more ED beds, the additional patients that need to be admitted will be admitted, but still have nowhere to go. So you'll just have more boarding and therefore more crowding. Furthermore, you're going to have to increase your staff, right? You'll need both nursing and physician staff to increase to care for these potentially new patients and the additional beds. But both, when the beds are full of these boarding patients, those new staff groups become less productive than originally intended, which when you're talking with a C-suite and there's less ROI, makes it harder to argue for and maintain that staff. Building a bigger hospital, on the other hand, might solve the problem. It depends a little bit on the admission volume that comes through the ED and the admission volume that comes from elective admissions or transfers, depending on what type of hospital you are. But it's also really dependent on the efficient processes on the inpatient side. So unless there is still a focus on early discharging planning, early discharges, optimal throughput, as I mentioned before, these additional beds could just lead to more bed block. It's also important to think about what beds you need because the types of beds that are added are different. So ICU beds are different than med-surg beds, different than surgical beds, different than observation beds. So unless you have the appropriately designated beds added to meet the requirements of what your health system needs, those added beds are going to be for naught.
Yeah, that makes sense. I agree with all the above. And you think about, a funnel and, the neck of the funnel, that's the throughput process, right? So if we build a bigger ER and it's the water is flowing in, but the neck is not changed in size, you're just going to have a bigger funnel, still full, still overflowing. So making a bigger ER does not necessarily make the process go away. Opening the neck of that funnel, possibly by increasing the number of inpatient beds, depending on, the capital needed to create that space, staff that space, could potentially improve things, but only if you're being really strategic about it.
That's right.
So Kraftin, talk to me about the NEDOCS score, or the NEDOCS score, and how, if at all, we should be using this to assess our ED situation.
Sure. So for those who are unfamiliar with it, I call it the NEDOCS score. Is one of several measures used to address ED crowding. It's a score that was developed back in 2004, actually. It's calculated from a formula that accounts for the number of patients in the ED, the number of ED beds, the number of hospital beds, the number of ventilators used in the ED, which is kind of a proxy for the ICU admissions, the boarding time for the longest admission, the time in the waiting room of the last patient bedded, and the number of admissions in the ED. So this NEDOCS calculation generates a crowding score on a scale from 0 to 200, ranging from not busy to dangerously overcrowded. The score has been studied extensively over the years, I'll say, with mixed results. It unfortunately doesn't really correlate with provider perception of crowding, and it's been found to both over and underestimate actual ED crowding. Plus, it's really complicated to calculate. I remember when I first got into operations, I tried to do it on shift, and even I was like struggling to get all the variables. It's just a lot of information to pull in there. I've seen some EDs that have it built into the EHR and incorporated it some way into a hospital surge plan. But I think there are probably other markers of ED crowding that are more accessible and translatable into ED and hospital surge plans. Maybe ED occupancy, turnaround time, your total ED volume inclusive of the waiting room, boarding time or number of boarders, and you're left without being seen rate. Although I'll admit that's a lagging metric, right? So we only feel that after this has become a problem. But any one of those is something that you might be able to use to look at crowding in a way that's easily communicated to those that need to know.
Okay, interesting. Yeah, I came across that as part of our operations in admin when we get to our surge capacity red, which is above gray. I guess when we're gray, we're dead. Red, we're still fighting, and we start looking at our NEDOCS score and how it flows into our surge plan. So good to know about.
Yeah, there are useful scores out there. I'll say that surge plans, you just reminded me, like there are people there that are just living in the red constantly, right?
Yeah.
And if that's the case, then the surge plan isn't doing what it's intended to do if
True.
no action can be taken that fixes that problem.
Yeah, that's fair. All right, so now let's parcel out our related but sort of possibly separate problem of ED crowding. Now, you may be overcrowded because half of your beds are taken by boarders, which we kind of talked a little bit about. In those situations, we're looking towards solutions we discussed above about sort of throughput and really an upstairs problem. We have to work cooperatively on that to fix it, and we need to be proactive rather than reactive. But there are times when admits are kind of moving up freely, and the department still kind of seems to be busting at the seams. What do you do in that situation, Kraftin?
Yeah, I think that's a great question. It feels like it doesn't happen frequently, but it still does. And I think this points to the fact that despite, any appropriate push you'd have to have hospital leadership take a strong stance on the boarding issue, we as the ED still need to take ownership of some parts of ED crowding that we can control, right? So ED flow, as we think about it, is typically broken down into 3 phases. Input, the in-process or throughput piece, and then output. And there are things that we can do to address each of these components kind of independent of boarding. So I'll say, starting with input, improving crowding from the input leg is really about reducing demand. So ideally, actions would have been taken outside of the ED to limit demand before it arrives, like extending primary care hours or having additional urgent cares nearby for low acuity volume. Now, we know that's not easy for us to do, in a silo, but ideally that's what would happen to reduce demand. When the volume's already arrived, there are a few actions you can take to address that excess demand. Most commonly, people put a provider in triage, where the provider evaluates patients upon arrival and then quickly discharges low acuity patients, or potentially orders tests on sicker patients that may need admission or longer ED care. But I'll say that approach, while it does improve your numbers, hasn't been shown to improve throughput and actually can have the opposite impact.
Interesting.
Yeah. But for the next phase, the in-process or throughput piece, we can work to improve upon those. This will also require some collaboration, this time with ancillary services like lab and radiology. So acknowledging that we don't have oversight of those departments, there are still actions the ED team can take to improve throughput, like identifying rate-limiting results and acting on those in a timely fashion, or using clinical decision rules to limit testing safely and not delay dispositions. And then lastly, I'll mention that, for the output piece, aside from admissions, which do account for a lot of ED output, we can focus on discharge patients because improving the discharge turnaround time can only help ED throughput. So specifically, optimizing that discharge order to depart time, which may just be a few minutes, right? It might not seem impactful at first, is actually a pretty big potential area for improvement. If you think about your ED volume, more patients are discharged than admitted, right? I mean, you're running an admission percentage, I'll say somewhere between like 15 and 25% would be my guess, without ever having set foot in your ED, which means that the rest of the patients, right, upwards of 70% are discharged. So every minute that you can get back on a discharged patient can be used towards another patient's care. So that time adds up, and then suddenly you have this big opportunity cost where you can see additional volume just based on shaving a minute or two off a discharged patient's turnaround time here and there.
Yeah, that all makes sense. Perfect. Well, this has been an awesome discussion about both ED crowding and boarding, and I'm going to try to do a summary, Kraftin, and I want you to fill in or add additional information as I go. How's that sound?
That sounds good.
Awesome. All right, so we talked about ED crowding and boarding. We talked about their kindred spirits. One often kind of leads to the other, right? We're seeing boarding as kind of an upstairs problem or throughput problem, and that we need to work with our colleagues to try to decrease our time to admission, time to getting the patient out of the department and into the appropriate bed. If we are backing up in boarding, then we develop crowding. So in addressing the boarding element, I really like the idea of the push versus pull model, of the ED being in charge of this patient is ready to go upstairs. We are ready to push them up into that space. And there's a lot of things that we can do that really are focused on the inpatient side and need to be done in collaboration with our CMO, CNO, to get these patients up into the space that they deserve, that provides higher quality care, etc. When we're unable to do that, I do enjoy your commentary on and appreciate in my own practice when upstairs nurses are able to come down and care for ED patients that are admitted because the quality of care is simply different. It's higher. They require a different level of attention, and the skills provided by an inpatient nurse are different than those of an ED nurse. So we want to advocate for that as well. And then the other thing that I just really liked and want to highlight in terms of the boarding and addressing boarding element are the structuralization or thinking about servers, the beds, the nursing, and the physicians. Many times the physicians or the APPs are sitting on our hands trying to get to patients in the waiting room, and we are not the rate limiting step. When we want to address our boarding issue, we need to look at which of these three servers is the lag and how we can address that and create a surge plan to enact proactively as we get into more crowded circumstances. We will have structuralized surge plans for you that are just sort of templated so that you can bring that back to your department and see how it compares to what you have or what you're looking to build. In terms of the crowding side of things, we talked about input, processing or throughput, and output. When we get into a particularly bad situation, we're thinking about our time to initiate care, right? And a commonly instituted practice is the provider in triage or the pit doc. I'm surprised and I find it very interesting that this will affect your time to see the physician, but maybe not improve any of your other metrics. And Kraftin highlights specifically really trying to target and be efficient with our time from discharge being placed and the patient leaving the department, because it's death by 1,000 paper cuts or the opposite, I guess, of that. If you can save 5-10 minutes in each discharged patient when you're discharging, 75% of your patients, you can aggregate a fair bit of time and really improve your efficiency. Kraftin, how did I do? Anything to add to that?
I think you did really well. I mean, this is a complicated topic. There are a lot of moving pieces. I think you hit on a lot of the details that I would hope people take away from this. I think big picture wise, if you're in the ED, you got to focus on what you can control. But it's also important to optimize your resources, collaborate with your hospital or health system leadership, and work to address, the boarding and crowding problems upstream and early. That's really the only long-term solution to this. Everything else is kind of a Band-Aid, on a wound that requires much more than that.
Band-Aid on a bullet hole, right?
I was going to quote Taylor Swift, but then I was like,
yeah,
no,
you can quote T Swift when you want. And just to add a final thought on that, if this is affecting your quality of life, your quality of work life, or your sensation of burnout, hopefully there's some information in here that just is giving you the opportunity to address these issues, right? To bring this back to your medical director, to bring it back to your C-suite and say, let's take a look at this, see what we have, and see where we can go from here. Because it does have a very large impact on the quality of our shifts, the quality of care we provide, and how we feel as providers.
Absolutely, Jay. I'm a huge proponent of the term I've coined, work wellness. So if you're looking to find solutions for your own burnout at work, get involved. See what the problem is and help everyone find a way to fix it. And then your life and the lives of everyone you work with is going to be better for it.
Fantastic. I love it. Kraftin, thank you so much, Dr. Schreyer, for joining us today, and we hope to have you back on the podcast soon.
Yeah, happy to be here. Thanks for having me, Jay.
Thank you for joining us for our conversation today on ED crowding and boarding. Hopefully you are empowered to be proactive, to make some changes, to prevent this from being a drag on your department. Know what else is a drag? Keeping up your procedural skills in these rare procedures. We have kits that deliver right to your home or office to keep your skills sharp in these. Click the link below to learn more.